So we've just gone through a very interesting talk on neurotrophic keratopathy and how we manage it medically until we found out that there's a surgical way which we can do it. And so I'm going to talk to you about the principles and evolution of corneal neurotization. Smruti alluded to the fact that the corneal nerves they come from the trigeminal, the ophthalmic division, and they lose their myelin as they enter into the stroma, and then enter into the epithelium, and there are multiple plexuses, and you can see that here the subepithelial, the subbasal plexus of nerves that we have. This is how it would look if you could actually show the entire cornea with the nerve plexus. This is a subbasal nerve plexus that we have, which forms a vortex here, and the cornea is the most highly innervated structure in the body. Okay, so it has about 1,700 more nerve fibers than anywhere else, and therefore is extremely sensitive. So, what is the importance of the innervation? Basically, it's responsible for maintaining ocular surface homeostasis. So the tear production as well as the epithelial regeneration are the two components that actually help to maintain a good ocular surface. In the absence of either one, the surface breaks down and we have problems. So how do the nerves contribute? So the nerves are responsible for secreting substance P. They secrete calcitonin gene-related peptide, and this is helping in the epithelium proliferation as well as healing. The epithelium, on the other hand, when it's intact, secretes neurotrophin 3, neurotrophic like nerve growth factor, serine neurotrophic factor, which are important for nerve survival. So you have the nerves, which will secrete substances which help the epithelium, and the epithelium, which secretes substances which help the nerves. So obviously, if the nerves are damaged, the epithelium is going to break down. We also have glial cell derived neurotrophic factor, EGDF, which helps in epithelial cell regeneration. And in addition, there's the reflex that we have, the blinking reflex that we have with an intact nerve pathway, as well as the fact that you have a autonomic supply to the lacrimal gland, which helps in lacrimation, all of which are responsible for maintaining an intact ocular surface. So if any one of these breaks down, you have a problem with the surface regeneration, and then you can have issues which Smruti alluded to. So coming back to how did this start? So it was Dr. Samy in 1972 who first described indirect corneal neurotization. Subsequently, nobody used the technique, and then Dr. Terzis described direct corneal neurotization, where a huge frontal flap was made and was folded down. The nerves were identified and then brought onto the ocular surface directly. But then that is a very involved technique which requires the help of a plastic surgeon, and it involves reflecting an entire forehead flap. So right from the corona, the flap is brought down and you expose the nerves, and then proceed to make that go underneath the underneath the brow, and it comes into the fornix, into the subconjunctival space, and then it goes around to the cornea. So that's a very involved technique, and it has its drawbacks, which I'll allude to later. So subsequently, Dr. Elbaz described a minimally invasive technique, an indirect corneal neurotization, which Smruti also mentioned, where you take a conduit from some other part of the body, and that is connected to a nerve on the other side, and then that is brought into the fornix of the affected eye. And this could be done in a minimally invasive way, which I think Dr. Rajesh would cover, using endoscopic techniques to kind of get the nerve into the area that we desire, as also for harvesting. And we are also able to use processed nerves, that is acellular nerve grafts, that is allografts. So all this while we've been talking about autografts used from the patient's own tissue, but then we are also able to get allografts. Not sure if that's available in India. Maybe Rajesh can guide us with that part later. But the autografts are what we are currently using in the surgeries that we do. So you have direct neurotization, where you take the nerve directly to the affected eye, which could be from the opposite side or sometimes a branch from the same side. And you have indirect neurotization, where you have the nerve which is functioning on the opposite side. You take a conduit, and I'll show you some pictures of that so you can understand further. So indirect, So indirect, you have the supraorbital and the supratrochlear nerves, or the infraorbital nerve, which could be used, where if this is the affected eye, you take the nerves, both of them, and direct them under the brow and into the fornix, and then this is fed around the cornea. Or you could take either the supratrochlear or the infraorbital, or a branch from the supraorbital, and then you bring that into the affected eye. It could be done for both sides as well, depending on how much of the sensations we still have. For indirect neurotization, obviously, because when you take a branch from, it's more involving. You require a long enough length of that nerve to reach that area. If you can take a nerve from, say, the sural nerve, or you can take a branch from the great auricular nerve or even from the great occipital behind. And the advantage of using the sural nerve is the fact that it innervates a sensory innervation to the dorsal part of the foot. It's a very small area which doesn't actually trouble you if you take the nerve out. And it's also easy to harvest that nerve. Its diameter is not too great so that you don't have problems with coapting the two. So you don't have a very broad nerve and a very small recipient branch, to attach it to. So you can take the sural nerve, connect it to the supratrochlear, and then direct the sural nerve into the phonics. And we'll be showing you the video subsequently to show how that is. So these are interpositional allografts or autografts that can be used. So how do you coapt it? So you have the supraorbital branch, which is a branch whose thickness kind of almost matches that of the sural nerve. And that can be coapted either by end to side, as you can see here, where you make a small window in the epineurium and you connect the sural nerve to that window and allow the fascicles, finally what the axons will grow through that. It's just a conduit. It serves for the nerves to grow through. Or you can do an end to end. So you connect the two nerves together, sural nerve to the supraorbital or the supratrochlear. Supratrochlear is a little thinner than the supraorbital and has lesser number of fascicles. So the supraorbital is what we prefer. And you have you connect them epineurium to epineurium, just suturing on the outside, taking a lot of care not to damage the nerve bundles inside. So that is end to end. So what would be the advantage of an end to side? Obviously, you're still retaining some sensation on the forehead part because you still have some nerves which are functioning, and only part of those nerves are traveling through this conduit to reach the eye. While when you do an end to end, you're using all the nerve bundles from that nerve. So therefore, the sensation on the forehead is going to be sacrificed, and that can be a problem for some patients. So this technique involves a contralateral nerve transfer, like I showed you, where you take the nerves from the opposite side and you transfer them. The bicoronal incision was what was done initially, and now we have moved to minimally invasive. So how does the outcome get affected by this? So as early as 3 to 8 months, there can be improved sensations going on, up to 3 years, 4 years down the line. The forehead numbness, which is there, which I mentioned, because obviously you're going to take a nerve and remove it from its original site of innervation and direct its neuron somewhere else. So you get some kind of numbness on the forehead, which is there for about 3 to 9 months, and the collaterals will grow in and cover that. But with this direct method that I was talking to you about, where the forehead flap is brought down completely, then there are risks of subgaleal. There'll be hematomas in that area, there could be neuromas, and there's obviously going to be some amount of alopecia and scarring, which is cosmetically not good, particularly if you're doing a full frontal flap and trying to do a direct transfer. So the ipsilateral nerve transfer is something we can do, where we take a small branch, as you can see here, and transplant that to the affected side. And you have the interpositional nerve grafts, like I was talking to you about, where you use branches of either the sural nerve or the great auricular nerve. But what is important when suturing it is that we should avoid tension on the nerve. We should be very careful when harvesting the sural nerve, and Dr. Rajesh will cover that part. We should avoid pinching the nerve, avulsing the nerve, damaging the fascicles within, and there could be the formation of some neuromas as well. So how does this actually work? So there are two theories. One is that there is release of nerve growth factor by the donor nerves, and there's direct sprouting of axons. And there was some evidence to show that when you stimulate the affected cornea, there are sensations which are felt on the contralateral side. There have been people who've done just a single case report on magnetoencephalography, where the opposite side of the brain records a response when you stimulate the innervated cornea. There have been rat models where they've looked at the labeled nerves and traced them back to the contralateral nerves. So you label the nerves in the rat, in the cornea, which has been innervated, and those labeled nerves have been traced back to the contralateral. So they say that there are some axons which are growing back from there. And what's actually happening is, and more believed, is that there's Wallerian degeneration happening when the nerve is transected. That leads to a Schwann cell dedifferentiation and proliferation, and the nerve actually just forms a conduit for the axons to grow into and innervate the cornea. But what exactly is happening on the cornea? And we've seen that there are IVCMs, in vivo confocal microscopy, that's been done, which shows you that there is some amount of nerve going back. But those nerves don't actually come back the same way as the nerves that we have with us. They are thinner, and they tend to have more myelin. So we heard in the beginning that the corneal nerves are all non-myelinated, which is important for vision. But these nerves don't lose their myelin so quickly, and they're much thinner and not as sparsely, not as thickly placed or closely to each other as the subbasal plexus that we had. They're thinner and more sparse, but they do the job, and Muralidhar is going to cover that in his talk on the outcomes. And Therefore, in conclusion, this is a promising surgery for neurotrophic keratopathy. It requires a team approach. We'll cover that because, as you see, we have an oculoplasty surgeon in this, we have a plastic surgeon here, and we have a corneal surgeon. So it requires a group of people who work with these patients to get the nerves and for the procedure per se. It does have some amount of a learning curve, and we require much longer follow-ups, but we'll cover the outcomes in the subsequent talks. So